So cultural case from in this session, we're gonna be in this model is not model number 2. We start with this model number 2 because we think that this will have the most useful information for all of you. Is the cultural case formulation and assessment using the DSM-5 cultural formulation interview. And our presenter for today is going to be Danita Gallegos, LCSW. So now Emily Moore will discuss more about this collaboration because this is a collaboration with Region 4. Emily.
Hi, thank you, Isa. My name is Emily Moore. I'm here representing the Southeast Mental Health Technology Transfer Center. We are very proud to be partnering with the National Hispanic and Latino MHTTC to bring you all this 4-part series that will be happening, as Isa said, every Wednesday throughout the month of October. So just to tell you a little bit about our Region 4 Center, the Southeast MHTTC is located in Atlanta, Georgia at the Rollins School of Public Health at Emory University. We are proud to serve the 8 states in HHS Region 4. Our expertise in public health programs, systems, research, and evaluation provides a unique lens through which we can address mental health priorities. The goal of our center is to accelerate the adoption of evidence-based mental health programs by providing training and technical assistance throughout Region 4. We use a public health approach to build leadership capacity and to provide mental health trainings and resources to providers, agencies, and communities across the Southeast. Again, we're very proud of this collaboration, and we are hoping that this 4-part series will help our providers and clinicians as they continue to treat our Hispanic and Latinx populations throughout the Southeast. And you can visit our website to find out more about what we're up to in Region 4. And there's a screenshot of our website right there. Thank you so much.
Thank you very much, Emily. So the MHTTC network uses affirming, respectful, and recovery-oriented language in all activities. And the language is strength-based and hopeful. It is inclusive. It's healing-centered, person first, and not judgmental. So we're going to continue with the disclaimer. So please do not reproduce or distribute this presentation for a fee without specific writing or authorization from the MHTTC network. And for today, our presenter is Danita Gallego. She works in school and she's doing like an amazing job in Texas. So Danita Gallego is a licensed clinical social worker in Houston, Texas, and she received a Bachelor of Science degree from Texas A&M University. And she also has a master's in social work degree from the University of Houston Graduate College of Social Work. She has experience working with families in medical social work, crisis response, school social work, and as a psychotherapist. Danita currently works at the University of Texas Health Science Center at Houston UT Health Texas Child Health Access through Telemedicine program in providing school crisis response and school-based therapy. So we are really happy to have Danita Gallegos with us. So there's not no conflict of interest in this presentation. So we're gonna do a poll questions. So I think back to you, Anne-Marie.
Yes, perfect. Let's go do the first poll question. And it says, the outline for cultural formulation was first introduced in the DSM-5. Please select one of the following, true or false. We have a 46% of our audience responding true, around 54% false. Cultural identity can help to develop person-centered approaches to diagnostic assessment and treatment planning. Please select true or false. We have 94% true and 6% false. And let's do the last one. It reads, discussing spirituality, religion, and moral traditions provides insight into the client's coping strategies and social resources. True or false? For the last one, we have 98% responding true and 2% false. Now I let you with our presenter, Danita Gallegos.
Hello, so I just want to put the slides up and double check that we can see it before we begin. Just want to confirm, can we see this presentation?
No, I cannot see the presentation.
Okay.
But,
Let me figure out what's going on.
now you should be able to share your screen with us.
Gotcha. Okay, got it. Perfect. Okay,
Now we can see it. Thank you.
perfect. Okay, so we'll go ahead and start. I know I tend to run over time every single time because there's a lot of information. And so I will go ahead and just kind of shift through the first few slides. We've already introduced myself. We've already spoken about NTTC. So first slide talks about just DSM-5 and how the DSM-5 defines culture. So I'm going to read off the definitions because they are important. The values, orientations, knowledge, and practices that individuals derive from membership in diverse social groups, which include ethnic groups, faith communities, occupational groups, and veteran groups. This is how the DSM defines culture. My little box. So the influence of family and friends and other community members are very important, and they have a large impact on the individual's illness experience and how they perceive the illness. So although we as clinicians and we as providers may have our definition from the DSM, or we have our certain criteria that the illness fits into, unless the individual actually has a perception of an illness, then they may not adhere to treatment, right? And that comes from culture. It comes from the people that they associate with, the people that they're speaking to. So even though we may have these fancy degrees and these letters behind our name, culture is very important to their process. So as we know, when we speak about culture and mental health, culture may influence the way a person identifies and names a mental health condition. So the way the person seeks help, the way someone experiences symptoms, conceptualizes and describes their treatment, and the way they participate in care, culture has an impact on that. Cultural identity of the individual. So the literature has documented these 6 sets of characteristics that are shared by most Latinos. There are more than this. This is just what is pretty common amongst the Latino group. So we have the Spanish language. There are various dialects that are also used, but the Spanish language is something that's very much in common amongst very much identified characteristic within the Latino population. cultural idea of personalismo. So in the future presentations, this will be discussed further, but personalismo is essentially the personal contact of something. How someone connects with someone is very important, and how they see them as a person. So it could be the cultural, of course, right now in COVID, it's not as common, but the cultural ideal and the cultural action of just hugging someone when you walk in a room. Simpatia is another common characteristic. It's social engagement and the charm of a person. Again, we go back to connection of a person. Familismo, so the familiism or collectivism that is within a community. Machismo is described as the manliness, the protector. It does have a negative connotation to the word in some cultures and some languages, but the underlying definition is very much based in protection of the family. Marianismo is womanliness, and it's very much based in the nurture of the family. And so these are 6 characteristics that are shared by most Latinos and most common in the culture. Psychosocial stressors and cultural features of vulnerability and resilience. So students and their parents may experience these type of stressors. So the statistics show that the Latino ethnic groups are more likely to experience the following high risk factors: poverty, inadequate housing, high proportion of single parent families, alcohol and drug addiction, acculturative stress. I believe that's one topic that's not as common knowledge. And I feel as clinicians and providers, that is one area that if we are working with a Latino population, we need to educate ourselves more on how just the acculturation process brings on stress to the individual and to the family. We go into discrimination, relatively low educational and economic status, and the history of conquest, oppression, defeat, and struggle for liberation. Again, this is a portion that as clinicians and providers, we are typically not taught within our educational system. So we do need to reach out and train ourselves and educate ourselves more on these topics. And that does have an influence on how the culture operates. And then we go to depending the students and parents and their acculturation level and immigration status. So there are some barriers that are faced when it comes to this that affect the vulnerability and the resilience. So the English proficiency scale, legal status is a big thing. Again, that's an ideal that is constantly changing. There's each administration that comes in has an influence on it. The politics of a local area has an influence on it, and the way a family adjusts to legal status may affect their mental health. So family separation due to immigration, issues of loss and trauma due to the immigration process, the ethno-racial trauma. And just to expand on that a little bit, ethno-racial trauma is the individual or collective psychological distress and fear of danger. So it results from what the individual or the family has experienced or witnessed in regards to discrimination, threats of harm, violence, and intimidation directed at their ethnicity and their minority group. This does stem from a legacy of oppressive laws, policies, and practices. So then we go back to the previous slide that discusses that history of oppression and how the policies affect the culture and in turn affect the mental health. Another huge factor is post-traumatic stress syndrome symptoms, and then loss of status in the community. So in different acculturation levels and immigration status. Status is a big thing. If you're immigrating from one country to the United States or any other country, really, there is going to be a huge shift, and the status does change. And if we want to make it relatable to just kind of more commonly relatable, it could be something as simple as I grew up in a smaller town and then I moved to a big city. In a smaller town, when you're growing up and you've been there from birth to 18 years old, you establish some type of status. And then when you leave to go to college or to move to a big city, you're starting over and you're reestablishing an identity and as a different status. And then there's loss of self-esteem due to the undocumented immigration status. So when we discuss privilege, there is a status privilege. There's some things that I can do as a citizen that someone who does not have citizenship status cannot do. And so those are factors that are really important to be aware of. And then a systemic assessment of culture should be comprehensive. It should recognize the person's identity as it shifts, and it should never be one-sided. This should also help the clinician in understanding the perception of someone who is seeking help and seeking understanding of the symptoms that they're having. So much of what clinicians understand as culture relates to a person's identity. What is a person's cultural background? The cultural background could be ascribed by others on the basis of perceived characteristics. In terms of the helping process, it's self-defined. Cultural identity is recommended. And so we may assign a cultural identity to a person, but it's more important that they self-define it and that you are looking to get their opinion and their perception of what their cultural identity is. So cultural assessments must inquire about the aspects of that identity directly to avoid stereotyping the patients or simplifying sociocultural phenomena based on the clinician's determination of the person's identity. Again, we go back to making sure that we are not stereotyping, we are not assigning an identity to a person, and we're letting that person identify self. So a comprehensive assessment should include ethnicity, race, geographical origin, language acculturation, gender, age, sexual orientation, religious or spiritual beliefs, socioeconomic class, and education. And the tool that we'll discuss in a few minutes has all of these factors. And then we also have to understand that the identity may shift. So identity is always framed in relation to the person's past history, current concerns, and future prospects. Also, the way that people think about and describe their identity depends on the setting and who they're conversating with. And those are all various layers that when we're having a conversation, we don't really take into account. When we're doing assessment, we may not take that into account, but there are different layers that are very important when somebody's identifying and self-identifying with a culture. Again, it's never one-sided. People have many facets or strands to their identity. The various strands that contribute to a person's identity may come from different places. It may come from their family, may come from the ethnicity, it may come from race and geography. So individuals who have lived marked cultural shifts may experience their identity in complex ways. Assessing the hybrid nature of identity is very important. And a comprehensive assessment of cultural identity helps the clinician recognize the influence of the identity, the stress, the stigma, the language, and other cultural factors of a person's clinical presentation, the symptom expression, the illness interpretation, and the help-seeking expectations. And so this is very layered, and there's not a common tool that's used to assess this. And so the CFI, which is the tool that we'll discuss, really covers a lot of this information. So the attention to culture may help clinicians So culture may also influence the way a clinician approaches mental health and the mental health treatment and variables, such as what constitutes a mental health disorder, the way we communicate, the way we offer support to participants, the way we may structure our work settings, which include the office, the waiting area, the pictures that are on the walls, and then the way that we develop a moral stance towards care. And then paying attention and being aware of cultural factors helps us avoid the ethnocentric thinking. So if we're coming from the ethnocentric type of thinking, then we may not be taking into account what their experiences have been and how that influences the way that they will be interpreting the information that you're giving. So we're going to discuss a tool that's very helpful, and this is the outline for the cultural formulation tool. So it appeared, the cultural formulation appeared prior to the CFI DSM-4. The OFC, which is the outline for the cultural formulation, is a conceptual framework that includes the following areas or domains in a narrative form. So this is all through conversation. Clinicians that utilize the outline for cultural formulation will assess the 5 factors. So the person's cultural identity, identifying which aspects of the person's cultural background are the most salient to understanding their presentation and their treatment expectations. And then we have the person's view of the mental illness issues and treatment. So that's the cultural explanation of illness. The third domain assesses for how the person's life situation affects the onset and course of the condition and the help-seeking options the person is considering. And then the fourth area evaluates the strengths and challenges facing the patient-clinician relationship. Is the patient worried about the provider's gender, their viewpoint, their perception of them? Is it overriding the information that they plan to share? We all learned that the therapeutic rapport and the therapeutic relationship is one of the most important factor of treatment. And so we have to be mindful of the patient-clinician relationship. And the cultural elements that are either avoided or acknowledged within that treatment and how that affects the treatment plan and the adherence to the treatment plan. And then last, we have the overall cultural assessment, which summarizes the information obtained so that it can be most useful to the clinical evaluation and the care decision. So that's going to be the last area of this tool, but it does go through these different domains. So we're going to get into more details about this tool. It's helpful. At the end of the towards the end of the presentation, you'll have 3 links where you can access the actual tool and the interview guides. They're very detailed, they're very helpful, but putting them in a presentation is a lot of words and it's graphically it's a lot. And so we're breaking it down. And so once you see the actual tool and the form, it'll all make sense as well. So the clinical formulation interview, the cultural assessment, the CFI, which is in the DSM-5, it's a cultural assessment directed at clinicians, administrators, policymakers, advocates, and other practitioners who work together to engage patients in the delivery of mental health care. The primary audience is the mental health clinician, but other stakeholders may find it useful. The purpose is to make it easier for providers to account for the influence of culture in their work. It's a flexible tool that may be used in a number of settings, and where selected CFI questions can also be interdispersed at various points during a usual evaluation. So it's extremely flexible. There's a lot of questions that are useful again, once you see the tool in its full form, you'll see how valuable it can be. We're going to go over the structure of it and then a few questions there that are embedded. So the design is used to be for any patient with any provider in a clinical setting. It's recommended as the first part of the clinical evaluation so that you're gathering history. As a social worker, I equate it to like a biopsychosocial assessment. You're gathering information, you're asking for the patient's viewpoint, and they're open-ended questions, so it allows the patient to share as much as they want. It could be used at any point in care. If you feel like you didn't use it in the beginning and it's valuable now, and the patient opened up a little bit more, and you may get more information out of the client or the patient because you've established that rapport, then you can use it then. And then it's used in cases of cultural differences that complicate the diagnosis assessment, uncertainty of fit between the symptoms and the DSM, ICD categories, difficulty of judging severity or impairment, disagreement with patient and client and clinician on course of care, and limited treatment engagement or adherence. So if you find that these certain cases are becoming difficult or you need a little bit more information, this is a good time to use the CFI. So a great introduction for it is to simply state, I'd like to understand the problems that bring you here today, or the concerns that bring you here today, so that I can help you more effectively. I want to know a little bit more about your experience and your ideas. I'll ask some questions about what is going on and how you're dealing with it. And just to remember, there's no right or wrong. We're simply having a conversation, and in this conversation, I want it to be helpful for both of us. And so that's just a simple way to introduce the idea, because if you're using the sheets, they may get a little nervous because it is kind of looks like you're using a checklist, but if you show them the papers, these are some questions that I want to ask, and it's just going to be helpful for treatment in general. That's a good way to explain it. So domain 1, and we have about 4 or 5 domains. We'll review, I believe, 4 of them, and then the last one is just the overall assessment. So domain 1 is just really getting to the definition of the problem. You want to see how they define the problem, how their social networks define the problem, and then what they see as the most troubling aspect. What's their perception? How is this influencing their life? And how do others see this as influencing their lives? So here are a few questions. Number 1, simple. What brings you here today? And they may share like, oh, well, my son said that I'm having this problem. They may share that, I've been experiencing this problem, but I haven't told anyone. But simply, how'd you get here? What brought you here today? Number 2, sometimes people have different ways of describing their problems to people in their community. How would you describe the problem? And what's troubling you the most? Pretty conversational. And then we go to domain 2. So domain 2 is the cultural explanation of the illness. So this explores the cultural, the aspects and how the person may relate to the symptom severity, as well as the expectations for treatment, any previous experiences with care, and expected course of symptoms. So again, it goes into how they perceive the problem, how the social networks perceive the problem, but then it dives a little bit deeper into how they identify what's their environment. And all of this is actually in the tool. So here's a few questions. The first 4 questions are included in this. And so why is this happening to you? What do you think are the causes of the problem? This will get a little bit into possibly faith. It could be something, I did this a long time ago, and I think this is happening to me now because of this. It could get into family history. Well, when I was younger, I had these symptoms and now they're coming up. And then you guys can read the questions for yourselves, but another marker is, are there any kinds of support to make your problem better? What social networks have been helping so far? And then the role of cultural identity. What are the most important aspects of your background or identity? Are there any aspects of your background or identity that are causing other concerns or difficulties for you? This may, I'm thinking of a teenager who immigrated, and this is only his or her second or third year in a public school. So their background could be that they either had different schooling or no schooling, and now they're being thrown into a public school system. And so that's important to understand their background and to understand how much of an identity shift that is. And is it causing any difficulties? Do they not want to go to school because of X, Y, Z? And then domain 3. So this directs clinicians to clarify cultural interpretations of the stressors and supports the associations with the patient's illness and the hopes and fears affecting levels of functioning. So we get more into help seeking, coping, and barriers. Sometimes we need to obtain collateral information from the patient's social network, and this could be included in this domain. So here are the 3 questions listed. Sometimes people have various ways of dealing with problems, like increased anxiety. What have you done on your own to cope with the symptoms that you're having? Pretty simple question. What are you trying? What has worked? What hasn't worked? 12, often people look for help from many different sources, including doctors, helpers, healers, counselors, teachers. In the past, what kinds of treatment or help or just advice and healing have you sought for your anxiety? And this may be a place where culturally they discuss having some type of healer in their community back home or where they grew up, or having some type of healer in the community here in Houston. I live in Houston, so that's why I'm referencing. Houston is a very diverse city, and sometimes people don't go to doctors. They want to go to a healer and try that first. And so you can probe a little bit more of how useful that's been, and stay open-minded and let them explain what treatment's been used. They may often say, or also say, that they've gone to a doctor before. The doctor has prescribed medication, but they didn't know what the medication was for. They didn't really feel comfortable asking questions. So the medication's just been sitting there for a little while, but they go to the community healer and they feel like the community healer helps them a little bit more. And so then we get into, okay, well let's kind of address this. Let's see if you have any questions about that medication. And then 13, has anything prevented you from getting the help you need? This could be finances, this could be transportation, and then a big one could be language barriers. It could be that this person went to, which is a case example that I've read before, this person has gone to the doctor for so many years and never understood the doctor because the doctor only spoke in English and the client spoke Spanish. And so, that's another reason they weren't taking the medication. They didn't understand and they didn't feel comfortable asking questions because of the language barrier. So, and then domain 4, cultural factors affecting current help seeking. So this portion addresses the clinician-patient relationship. The clinician may say, now let's talk a little bit more about the help that you need now. And then you'll gather some expectations. I just came today because my daughter told me to come today, but I don't really know what to expect. Okay, so let's dive a little bit deeper in this. Role definitions and resources. each bring to the encounter. And so this is a part where the clinician and the patient can discuss resources that may be available through the clinic or the agency or the just clinicians networks, and where the patient can really talk about things that the resources they have in the community that have been helpful, whether it's the church, the adult children that have been helping. And then we go into the client and social networks preferences about care. So this is my recommendation. Does it sound pretty good to you? Does it not sound good to you? And let's discuss why. So, and then you want to be aware, as a clinician, you always want to be aware of how the patient is perceiving you. There is a term that will probably be discussed in the future with Dr. Evans, who's presenting the other webinars, and it's called respeto. And in that, it's this idea that a doctor's word is everything. So you just agree with it. And so if the perception is the doctor has more power, the doctor has more authority, I don't question this person's the expert, then someone may come into a treatment plan just nodding their heads at everything because of this power imbalance. And so creating a relationship and trying to understand how the patient perceives you may have a strong impact on that. If you are a clinician that gathers that this will be an obstacle, then it's an area to explore a little bit further. Because it will affect treatment. Domain 4 questions. What kinds of help do you think would be most useful for you at this time for your stated problem, for the anxiety, for your nervous system, things like that. 15, are there other kinds of help that your family and friends and other people have suggested that would be helpful for you now? Sometimes doctors and patients misunderstand each other because they come from different backgrounds or have different expectations. So again, we go back to be aware of how the patient or the client is perceiving you as the professional. And then the last one, have you been concerned about this? And is there anything that we can do to provide you the care you need? So that's the actual core assessment. I want to say that's about 2 pages long. It has instructions, it has feedback. The actual tool is very helpful. You could literally just sit there and read it off and still have a pretty good conversation. And then we go into a supplemental model. The supplemental model is several pages long. However, it has tons of helpful questions on there. I want to say it's about 14 or 15 pages worth of various categories, and under each category has more questions, has about 4 or 5 additional questions that would be helpful. Again, you don't have to use the entire 14 pages or 15 pages. If you feel like there's an area you need to explore a little bit further, this would be the tool to use. And again, there's a guide, there's statements that are in italics that are for you as a script. It's super helpful. So it is broken down into various sections. I want to say it's 12 sections. Yes, it's 12 sections. And so again, each section has 4 or 5 questions underneath. So the first section is the explanatory model. So an illness explanatory model usually includes a patient's ideas of the causes of the problem, about its psychological, somatic, social, and or spiritual effects over time, and about what would be the most appropriate and effective treatment. So a client is always going to have an idea before they step through the door of what they think the treatment should be. Now, whether that's, grumpy person saying, I don't need treatment, I'm just coming here and I'm just going to hear what the doctor says. That's still an expectation. Patients' explanatory models of their symptoms and complaints may differ from those of the clinician, and this difference may influence the help-seeking process, the adherence process, and the clinical course and outcomes. So these models may also be shared by those around them within their cultural context. The questions developed in this particular section elicit narratives on general understanding of the problem, illness prototypes, causal explanations, course of illness, help seeking, and treatment expectations. So through this portion, it can maximize treatment engagement and adherence, increase positive expectancy, build empathy and therapeutic alliance, address catastrophic cognitions that they may have, and address any stigmas that they've heard, whether they've heard it on media or through friends. This is a time that you may get this information, and it's a good time to address it. And then we go to level 2. I'm sorry, section 2. Section 2 addresses the level of functioning. And so we have to remember that in some cultures, successful functioning may be largely limited to paid employment, financial stability. So in others, self-satisfaction may be perceived to be more important. So it's really dependent on the culture and what the culture envisions as a good level of functioning. So technologically developed cultures may value cognitive abilities above paid manual work. That's just an example. So this module aims to address all areas of functioning that may be affected by the psychological distress. It includes activities and responsibilities, the ability to work, financial situation, social functioning, inability to experience pleasure, lack of functioning that most concerns the individual, and family concerns. So this section is a good way to clarify their perception of successful functioning, and then how to address if they're not functioning at the level that is healthy. And then we move on to section 3. Social networks can play a part in the onset, course, and outcomes of mental health disorders. They are defined as all interpersonal relationships having an impact on a person's life. For the DSM-5 purposes, that includes family, friends, and other social contacts through work, places of prayer, worship, and other activities or affiliations. This could be a softball team. It could be the neighborhood and who's actually, who the person's neighbors with. Social networks may facilitate or impede access to help, mobilize resources to manage emotional difficulties, and provide support as basic need. So this module covers this module covers 5 domains. So the first and second elicit a description of the key individuals in the person's social network and their awareness and understanding of the actual mental health, the issue at hand. And so it's going to have the client kind of search a little bit, who are they around and how do they perceive what's going on? And then the third domain examines the social and behavioral responses of that social network. How are they responding to this increased anxiety? Are they avoiding it? Are they concerned about it? How does that influence you? And the fourth domain includes the patient's perception of the extent to which those in the social network have made the difficulty better or worse. How is it impacted? Is it helping or is it not helping? And then the fifth section examines the involvement of the person in the social network and the mental health care of the person. And so this is a pretty significant area. There's various questions, 5 questions that will really help examine the patient's circle And as we all know, our inner thoughts are strong, but when it comes to people around us, sometimes they have way more influence on us than we realize. And so this is a good area just to explore and maybe have them draw a sheet of paper and who's in your circle, who's outside of that circle. Kind of write down keywords, like let's explore this and let's see how it's helping or not helping. And if it's not helping, how can we make this a better process for you? The fourth area is focused on psychosocial stressors. So the psychological stressors supplementary model provides clinicians with a method for exploring the cultural aspects of the stressors. And it may be exacerbating the difficulties that patients present. So cultural influences on the perception and experience of the stress are substantial. So compared to the majority population, immigrants, refugees, and members of cultural minorities may be subject to additional stressors and have access to fewer resources for coping with them. So culture is essential to the process of stress activation. So cultural values and the meanings are fundamental for the appraisal process. Resources available for coping may depend on cultural factors. Frequency and nature of the stressors may vary depending on the person's history and the positioning within the host culture and cultural background. I know populations that I've worked with, and when you are living in a city that has different enclaves, this is important because you dive into what's available, what's around them, that is culturally supportive. And so this is a really interesting area to explore, but it has to be explored with an open mind, because it's very easy to be stuck in that ethnocentric view and to not understand what they're talking about. And so if you're talking to someone who is already curious and not too sure if you're going to understand or judge them, they may shut down when it comes to this area because they may not feel like you understand. And one example could be calling the police. We have a problem. The police may not be a resource available, and it could be related to immigration status. It could be related to discrimination that has been experienced in the country so far. It could be related to how law enforcement has treated a family member or things that they've heard on the media. And so our version of resource, and it could be related to home country, and if it wasn't safe to call the police in their home country, and now they've brought that idea with them during the immigration process. And so we have to be open to that and really understand where they're coming from when it comes to the cultural values, meanings, but then also the resources that are available. That's a very layered topic, but the questions in there are very helpful in exploring this. And then we go to section 5, spirituality, religion, and moral traditions. So assessing this kind of information provides insight into personal coping and social resources, and it also allows the expression of beliefs about existential meaning that may contribute to their perception or the presenting concern. One big one is fatalismo, and again, that might be discussed in a later workshop. So fatalism, the idea that I'm just going to leave this in God's hands. And if that is a strong belief, this is an area where you're able to explore and just kind of understand. It's not an area to provide, it's not a preaching moment, right? But it is an area to explore and just kind of hold that information, put it in your pocket. Let's see how this is going to influence our treatment. Let's see if we can not necessarily work around it, but work with it. And so it allows the patient to discuss this more in depth. So the CFI provides a framework for exploring this, and this is a part of their identity. For most people, spirituality and religion are a strong part of their identity. And then section 6, cultural identity. So this section is intended to help clinicians develop practical, person-centered approaches to the diagnostic assessment and treatment planning. So this includes the national, ethnic, and racial backgrounds, the language, the migration process, the acculturation process. All of these factors play into someone's cultural identity. For example, a third-generation Mexican American, there's still some type of cultural identity there that may be different than the majority population, right? So it also addresses cultural identity as it relates to spirituality, religion, and moral traditions, and then cultural identity as it relates to gender identity and sexual orientation. So such identities may in turn guide the illness models and the expectations of support and care, help-seeking patterns, and other variables that may be key in the assessment process. Again, there are several questions that are supportive to this topic. And we go to coping and seeking. The way someone has sought help in the past reveals important information about how they conceptualize the problem. Previous treatment failures and successes, stigmatization, access to treatment, and current expectations. All of that is important and important information to see how it's influenced and how it will influence your treatment plan. This information may reveal local resources of resilience, how someone's overcome treatment barriers, and how problems are typically addressed. And so you may discover some patterns in there that you can help with. And then the patient-clinician relationship. So this may promote or impede adherence and retention. The CFI facilitates exploration of the cultural aspects of the interaction between the patient and the clinician. It examines the present relationship and the context. So this module enables improving communication in the relationship. And the goal is to assess the role of culture in the therapeutic relationship. So how a participant and a clinician experience, interpret, and shape their cultural repertoire, and how the relationship is influenced as a result. So by using the CFI, the goal is to promote communication, promote understanding. On the clinician's part, of course, you're analyzing information. Along the way, you're taking in how the patient has been has adhered to treatment or not adhered to treatment, why there's been some non-compliance, why the quote-unquote medication that's been prescribed previously is not working. Maybe there's a misdiagnosis. So you're taking all that information in, but on the clinician side, the goal is to help them build trust. And the goal is to help them become more open. They may have tried to in the past and they were shut down. They may have been just asked a checklist of questions, yes or no questions, closed-ended questions. And this may be the first time that somebody's actually listening to their story. And as we know, our childhood has a lot of impact on the way we function. And so sharing the childhood story, sharing relationship stories, sharing migration stories in a safe manner really allows for better treatment process. The next section is for school-age children and adolescents. So given that children and adolescents are influenced by many cultures they belong to, it could include school, family, and community. It's important to include multiple perspectives. So you want to get input from family and other perspectives. There is another tool, actually within this, the questions are age-appropriate questions that will help the clinician in treatment planning and assessment. I've worked in medical settings and school settings before, and this is a tool that's very useful when speaking with families. Then we go to older adults. So we explore the unique identity of older adults and how they may relate to clinical care and cultural attitudes in this developmental stage. So medical conditions may require some collateral participation from the older adults to explore the medical history and explore all of the patterns that we want to learn from to help with successful treatment. And then the next section, immigrants and refugees. The CFI can provide important clinical information when it comes to this population. There can never be enough understanding of this population because it's so layered. There's so many dynamics. So this portion includes pre-migration difficulties, migration-related losses and challenges, ongoing relationships with the country of origin, resettlement, and future expectations. So refugees represent a subgroup of the migrants. Typically, they have involuntarily fled their country of origin because of political, religious, or ethnic prejudice, imprisonment, or armed conflict. They've had imprisonment or armed conflict, and involuntary migration can present differing clinical problems. And this doesn't just include recent migration. You could have a client that migrated 15 years ago and is still having some residual effects of that process. So the age of migration, the stage of development, how old were they when this happened, is very important to the process. And then our last one is caregivers, assessing the role of cultural conceptions of aging and aging-related transitions in the patient's illness experience. So knowing how to best support the caregivers requires an understanding of the role of culture in shaping the caregiver's roles, values, and ethics. Although the cultural values are often shared by the caregiver and the patient, there may be important differences. Awareness of distribution of the different aspects of caregiving will help the clinician navigate the informal systems of support. Who's supporting this family, and what is their relation? What is their role? How often are they there? Is it an expectation that they're there all the time? So how conceptions of aging shape illness, meaning, and coping strategies. And another big factor is the acculturation process. If we have a first generation elderly adult and the caregiver is a third generation person, what's the influence of that? What is their view of that? And so that is the portion, the supplementary model. And so the first part of this presentation went over the core CFI. That's about the 2-page model. There is an informant version that's to use with a caregiver, a guardian, someone who is with the client. Latino families, it's not uncommon for multiple people to attend a doctor's appointment with them. And so this is a chance for you to get permission from the client to get collateral information, and you can use the informant version for this. And then the CFI was that 12 points the section that we just went over that has multiple questions under each of the 12 categories that will let you dive a little bit deeper into it. And then this is an application, but we're not going to go through the questions. There's a really good, I think it's like 20-page case example that I've read before that gives a lot of great insight to the CFI and how important it is, and the different barriers that were overcome once the client was able to really answer these questions and tell their story. And so I think we can send that out to you guys if needed. But reading that really helped me understand why this tool is so important. And so I just want to hand it off, see if there are any questions. And then these are the next modules that will be discussed, and Dr. Evans is amazing, and so you'll really enjoy the next 3 modules.
Danita, thank you very much for your presentation. Yes, we have some questions here. So the first one will be, how long does it take to administer the core CFI?
So that's a very subjective question. It really depends on the responses from the client. And again, it's a flexible model. And so if you are planning to have several sessions with this client or multiple follow-ups, you can dive into the section that you feel might be most important, or the section that they have kind of mentioned some keywords before. Maybe they've mentioned that I'm just going to leave it in God's hands. And so you want to explore the spirituality section a little bit further if you are lacking time. But it could definitely average an hour, 45 minutes, an hour if the client is really opening up. And so my suggestion would be to really not study the forms beforehand. I feel like a lot of clinicians and providers are familiar with these types of questions, but just review them and see which, maybe highlight a few areas that you want to explore that you think are important, and just go from there if there's a time limitation.
Thank you. We also have a question regarding if the CFI, if it is in Spanish.
Yes, I believe it's in multiple languages, but we would have to search for that. I haven't used one in Spanish, and so I would have to, but there is one in Spanish.
Okay. We have another comment, but also comment and question. It said it is not possible to ignore cultural factors associated with magic thought, seriously rooted in the belief systems of the Latin population in the US. Even after generation in the US, Latinos do not stop thinking like Latinos. I mean, the discussion is to standardize therapeutic procedures to the Latin population, or standardize the Latin population belief systems to the therapeutic procedures.
So the question is, I want to make sure I understand the question. Is the question that this tool is trying to standardize a certain way?
Yes,
Okay.
like if we standardize the therapeutic procedures to the Latin population, or the other way, or if we standardize the Latin population belief systems to the therapeutic procedures.
Okay, I want to say that I understand the question, but of course there's always room that I don't. But if I'm understanding it correctly, the expectation is to understand the culture, right? And so the example that I'm going to give is I'm a multi-generational, I think I'm like 3rd generation Mexican American. And we still do the egg, we still do the limpia. And so if a provider is asking questions about different healers and different practices that have been used, and medication has never been used before, but they've had the limpia done, they've had the egg done, that might sound a little shifty to a provider that's not familiar with that practice, right? So this gives us a chance to ask, well, what exactly is that? You know, those who are understanding of the process know that it's not a harmful process. There's no chemicals that are being injected into the body, or there's nothing, there's no chemical imbalances going to happen because of the egg, right? And so the practice, I'm sorry, the expectation is to understand and understand what practices they've been using so that you can supplement that, right? And so if it's just Olympia and it's just the egg, then continue to do it. That sounds great. It sounds like you get a lot of positive effects from that. It sounds like you're getting a little bit of strength after you do that. Whatever the response is to that, it's validating and understanding that process, but at the same time, giving it an opportunity to explain what therapy could do in addition to the Olympia, or medication could do in addition to the cultural practice. And so I don't think there's a standard, there's no expectation to standardize in one way or the other. The expectation is to understand the cultural effects and culturally what this client has experienced and how, and as you're analyzing and as you're gathering information, how that might supplement your treatment strategy and your therapy strategy, your planning strategy. That makes sense.
Thank you very much, Danita. We don't have, okay, we have another more question. The last one will be, how do you create a cultural formulation outline with a client?
How do you create an outline?
Yes, how do you create a CFI outline with a client?
If you look at, let me go back. These are already created. So if you look at the DSM, it's already created in there. And so these links will link you to that outline. You don't have to create anything yourself, which is the beauty of it. These links will do it for you. And so, as I mentioned earlier, the core CFI were just those domains that we went through earlier, the 4 domains. And then the supplementary models is an elaborated version of the core CFI. So the supplementary model will give you 12 categories. It's something like 14 or 15 pages of questions. And it's just to supplement if there's a category that you need to go into more depth from the core CFI. So it's already created for you. And the DSM, it is actually in the DSM. It's towards the back. I can't remember that actual page, and I have my laptop. I have it under my laptop to prop up my laptop, but it is towards the back. There's a whole cultural section in the back of the DSM. It's pretty interesting, but it's also back there.
Thank you very much. I have used it and it's really good. So I want to thank you, Danita, for your presentation today, and also thank you to all the participants and the questions that you made. I just want to remind you all that you will receive a link where you can answer our questionnaire about today's presentation. So I hope all of you can stay with us for the next Wednesday presentation. And thank you, all of you. Thank you again, and have a nice day. Bye.
Thank you.